Okay, there are some variations, however. So if we look again at these visceral smooth muscles, these single unit ones, you can also get spike potential, which I just showed you over there, and you can get action potential with plateau. This is the plateau you could see over there, so it stays depolarized for a long time. Sort of reminds you of the cardiac action potential in a way. These action potentials last for 1000 milliseconds, the ones with the plateau, unlike the spike potentials, which only last for 10 to 15 milliseconds. So the action potentials with plateaus, they give prolonged contraction, like the ones in the uterus and the ureter. Some smooth muscles are self-excitatory. Okay, they are able to maintain, they are able to excite themselves because they have some cells around them which are able to maintain basic slow wave rhythm, okay, of the membrane potential. So there is again this fluctuation that you could see, and we'll go into this in GIT. It's also known as basic electric rhythm. Okay, so there will be a change in the permeability to different ions. Calcium will enter into the cell during a slight depolarization, and then sodium, potassium, ATPase pump will work more and make the cell negative again. So this fluctuation between calcium and sodium, potassium causes this kind of fluctuation. This is your basic slow wave rhythm. What happens is, so it's fluctuating, and then one time a neuron is going to release some neurotransmitter, or something is going to stimulate the cell, and it's going to cause the cell to cross the firing level, which is shown in this dotted line over here, and then you get these spikes on top. These are your action potentials, but they are not always necessary for the contraction of smooth muscle. Now, smooth muscle contraction, it does something called pharmacomechanical coupling. It's where we are able to see there are some differences between smooth muscle contraction versus skeletal muscle contraction. So first of all, what happens is you can stimulate the smooth muscle contract with drugs, with certain chemicals, or also there is a mechanical component that plays a role also over here, which we'll talk about. Smooth muscle contraction is slow compared to skeletal and cardiac muscle, and calcium is the major ion, like I said many times, for responsible for contraction. So the more calcium that enters into the cell, the more is the strength of contraction, the amount of contraction that takes place. The sarcoplasmic reticulum has very low calcium stores. So yes, there is some sort of induced calcium release that takes place, but it's not going to have a large amount of calcium stored in the sarcoplasmic reticulum, like how the L tubules used to release calcium in skeletal muscle. So the smooth muscle gets calcium from the intracellular and extracellular sources, and here we are going to talk about these different sources. So the extracellular calcium sources are: number 1,4 dihydropyridine voltage gated calcium channels. So when you depolarize this cell, you open these channels and more calcium comes in. Then you have different ligand gated channels. We'll go through them as we go to those respective parts which where they are involved. Okay, so there are these receptors called GQ receptors, which release IP3 and diacylglycerol, and IP3 causes the release of more calcium from the smooth endoplasmic reticulum, which is going to cause contraction. So this is how these different ligands work. And then you have stretch activated calcium channels. So sometimes you stretch a muscle, and there are some channels, calcium channels, that open up because you stretched open this channel, so the doorways open up even more and calcium is able to enter in. Okay, so these are stretch activated calcium channels, and there are small number of unregulated leaky channels also, and store operated calcium channel. Next we have the intracellular calcium sources. So you have the IP3 I told you, which is made, and this IP3 will go to your smooth endoplasmic reticulum, releasing more calcium from that. So then after that we have ryanodine channels. Ryanodine channels, again, they are located on your smooth endoplasmic reticulum, and they will release calcium. And you have calcium induced calcium release, just like in your cardiac muscle. All right, and then let's talk about the pharmacomechanical coupling. So this algorithm is again another beautiful piece of art which we are going to go through right now. Okay, number 1, what happens is pharmacomechanical coupling. How does it happen? You have to increase calcium levels in the cell. So you can do it by releasing different ligands, like I said over here, causing increase in calcium level. You don't always need an action potential. Please remember this. So when you increase the calcium levels from any of these extracellular or intracellular calcium sources, 4 calcium ions will bind to calmodulin. So you make a calcium calmodulin complex. And now what's going to happen over here? You are going to get the activation of calmodulin dependent myosin light chain kinase. So this is a very important thing. So the calcium calmodulin complex is going to activate your myosin light chain kinase. Okay, it's one of those light chains which are present on the myosin, attached to the myosin head, and here this will help in activating the cross bridge cycling. And the other thing on the right side, you see this arrow, calcium calmodulin complex is going to cause phosphorylation of calponin by activating a kinase enzyme, removing the inhibition on myosin ATPase activity. So you are going to phosphorylate calponin because of calcium calmodulin complex. It's going to phosphorylate calponin, and it will cause an enzyme, that a kinase enzyme, meaning it takes PO4 phosphate and puts it on other things, and this kinase enzyme is going to remove the inhibition on myosin ATPase activity. So it's the myosin ATPase is going to use up ATP for energy and do cross bridge cycling. So all of this helps in the phosphorylation of myosin light chain kinase and in the myosin neck. And then what happens is there will be an increase in myosin ATPase activity of myosin head and binding of myosin and actin. So now what happens is you are going to generate force. This is known as contraction. Okay, so you contract because of this myosin ATPase activity increase over here. Okay, so the myosin head's activity increases. So you get a ratchet like action. Okay, it's like a ratchet or a spanner, if you helped your father around in the work when he worked around the house. So ratchet like action or cross bridge cycling takes place. So how does it work? You have your thin filaments over here, actin, which are pulled towards the center of the of this organization. So if we see the dense bodies over here, there are the black lines are the actin, and the myosin is the green stuff in the middle. So the myosin is going to pull these actins towards the center. So from here you have the release of ADP and PI that happens during that time. Eventually what happens is when you want to stop the contraction, when the body says that's enough, then there will be a reduce in the cytoplasmic calcium levels. This is because of calcium pumps or 3-sodium 1-calcium exchanger that gets rid of calcium from the cell cytoplasm. This causes the dissociation of the calcium calmodulin complex, so calcium goes out of the cell or gets taken back into the smooth endoplasmic reticulum, and this activates another enzyme called myosin light chain phosphatase. First it was myosin light chain kinase that caused contraction. When you cause relaxation, it is due to activation of myosin light chain phosphatase that is going to remove the phosphate group from the myosin regulatory light chain, which was phosphorylated by the calcium calmodulin complex in the beginning. Now this is going to cause either relaxation or something called latch bridge formation. Just before we go ahead in this, I want you to know that the myosin light chain phosphatase is inhibited by an enzyme by something called Rho kinase. Okay, and Rho kinase, by inhibiting myosin light chain phosphatase, will interfere with the relaxation of the muscle. Okay, it will inhibit this. So there's a drug called Fasudil, which is used in angina and pulmonary hypertension, that will cause smooth muscle relaxation by inhibiting the Rho kinase that would inhibit the myosin light chain phosphatase over there. Okay, and this inactivation via dephosphorylation of the myosin light chain, regulatory light chain, can cause relaxation or latch bridge formation, also known as tonus. Now what is this latch bridge formation? So you have that myosin and it is bound to the actin. Now when you dephosphorylate remove the ATP from here, the ADP and the ATP. There's no ATP. Now what happens is the myosin does not necessarily detach from the actin. It would instead stay attached to the actin even after it has pulled the actin towards the middle of the cell. So even after dephosphorylation, your cross bridges continue to cling on for some time, so it maintains the tone. And this sustained contraction with minimal ATP expenditure makes it very efficient. An example is vascular smooth muscles and in the intestines, where this latch bridge formation takes place. Another concept is plasticity. So plasticity, on stretching a visceral smooth muscle, when you stretch it, the muscle tries to contract back. Okay, it increases tension. So if you take a tubular structure and you try to stretch it out, it will squeeze back. For example, have you ever noticed how laxatives work? You take some fiber like husk or psyllium, and use take that with a glass of water, and that goes into your gut. It absorbs a lot of water and it stretches your gut, the walls of your gut, and what happens is the gut will push back, and this helps in propelling and causing peristaltic movements until you have a nice bowel movement. So we use this in constipation. So what happens is the muscle in the beginning stages would contract back and increase the tension. But if for some reason you are able to maintain that tension for a long time and the stretch for a long time, the new diameter of the viscera, it's held in this tension for a longer time, what happens is the tension levels will reduce eventually due to reorganization of the architecture of the muscle. So the muscles get reorganized in a way that it will say, no, I think this is the new normal length we should be at. So there is no resting length or optimal length for a smooth muscle. It just changes because the entire structure is it's like the Terminator. It's able to mold itself and change the shape of its own body, its own organization, in a way that allows it to change its length, its optimal length, or the length at which it accepts itself to work at, to function at. So if we look at bladder on this tension as an example, in the beginning you get this increase in tension and you want to pee, but imagine you don't go to the bathroom for some time. You have to hold it in, like you're sitting in an exam and you're not allowed to leave. Then what happens is because of that volume of urine that's in the bladder increasing, the tension after some time reduces because the smooth muscle undergoes plasticity. And this happens for a fair amount of time, until we reach up to 400 ml of that's usually the maximum capacity in most bladders. So what happens is from 0 to 150 ml, nothing happens, everything looks good. But then after 150 ml, when you reach up to there's not much change in the tension. And then after some time it gets really increased after a while over there. So the increase in tension during the later stages, when you've crossed the limit, causes the bladder to contract forcefully.